Is it seen?
Yes.
Yeah, so good afternoon, everybody, and many thanks to Dr. Amit and the scientific committee for giving me this opportunity to speak on medications versus SLT in early POAG, and I shall speak on behalf of medications.
Yes. You can make it slideshow. Yeah.
It's a slide.
Okay.
Yeah. So I have no financial interest. So we all know burden of glaucoma in India is quite heavy, with almost 11-12 million of people suffering in India as of now. Prevalence rates of open-angle glaucoma are all the way from 1.5 to 3%. And topical anti-glaucoma medications have been our main sustaining force as far as treatment of glaucoma is concerned from the last century itself. As we see, the timeline of anti-glaucoma medication started all the way in pilocarpine in the 1800s. We had Timolol somewhere in the 1980s, and then in early 2000s we had a prostaglandin analogs, and recently in the last year or two itself we've had Rho kinase inhibitors as well. So these are the plethora of options available for us in the form of anti-glaucoma medications, either PG analogs, beta blockers, brimonidine, dorzolamide, pilocarpine, and of course the new kid on the block, which is either Repasodil or Netasodil, which is the Rho kinase or the ROCK inhibitor. There's also options of fixed drug combinations of any of the above. My approach to this debate is going to be from a very practical perspective as to which is better, which is not, keeping in mind general ophthalmologists, single private practitioners who practice in various parts of the country. Anti-glaucoma medications, topical, have easy access, widely available all over the country, Kashmir to Kanyakumari, Maharashtra to Arunachal Pradesh, everywhere, from original to generic molecules at varied cost. So you can depend on what is the status of the patient, you can prescribe accordingly. There's a robust and well-documented IRT drop, whether individually or in combination, which is well known. And in early POAG, usually one drug is sufficient for adequate IOP control and can always add on as required. Newer drugs, especially drugs like tafluprost, have relatively fewer side effects, lower local and systemic side effects, and effective use of lubricants also keeps the ocular surface moist. So the fact that the glaucoma, anti-glaucoma medications have a lot of issues can be remitted. With adequate chair time, I feel counseling and education, one can improve adherence and compliance rates of patients, which is one of the major adverse effects of medical therapy. You sit with them, show them perimetries of patients who have remained stable, who have progressed when medications have not been used, and I'm sure if you give them more time, we can improve their adherence and compliance rates. In comparison, SLT or selective laser capsuloplasty, is it superior compared to medications to control IOP? No, it may be equivalent. As we see in this study of Journal of Glaucoma in 2012, there was a 20% drop both in SLT as well as medications. And as Dr. Faisal spoke about the LIGHT trial, but he forgot to mention that target intraocular pressure in SLT was seen in 93% of eyes, and the target IOP was seen also in medication in 91.3% of eyes. So there's no major change as far as your ultimate endpoint, as far as your target IOPs are concerned. And again, this study also showed us that IOP reduction was almost 20% more in medications as compared to SLT group, which was in BGO in 2019. What are the issues with SLT? Is it accessible? Is it available? I'm not too sure. In a city like Bombay, which has 1,200 ophthalmologists, we have barely 5 or 6 machines. It's extremely difficult to find an SLT machine to do it properly also. Rental machines also have issues with visibility, etc. High non-responder rate. Almost 25% do not respond to SLT. Cost of each sitting with a non-responder is going to be difficult for us to tell them that you spent X amount and sorry, you have not responded. Again, my fourth point is debatable. Technology in glaucoma has not always stood the test of time. Example, GDX and HRT, which now the machines are not even being manufactured. I buy an SLT machine, after a few years, the company stops producing it. I may not be able to serve it, not be able to repair it. Patient compliance follow-up is important, and even in treatment naive versus already treated patients, response to the SLT differs in these cases. So my verdict is AGM versus SLT is a no-brainer. Go for medications, reliable, accessible, multiple options, and can be used in all glaucomas and not only open angles. Thank you.
Well, thanks, Maya. We are actually having just 30 seconds, so I can ask Dr. Mohideen to quickly give a comment and then we close the session, please.
I think I choose SLT as the first medicine to use for early glaucoma.
Okay. Dr. Murali, any last comment?
Yeah, I think definitely some of the points which Dr. Maya mentioned are good, the availability, acceptability, and so on. But I think I don't agree with this non-responder rate. I've been doing SLT for the last over 20 years now. I think the non-responder rate is less than 5%. Only. It's something similar to medication. Many of our drugs also don't work. And of course, needless to say, SLT needs a special degree of skill. You need to have a good gonioscopy, and you should not start treating pigmented Schwalbe's line as trabecular meshwork and so on. Those issues still remain. But given the balance between availability, flexibility, and other things about the SLT, I would still offer it to patients, but not all patients take it.